We are going to start herpes simplex keratitis, and it is the cornea part 7. So, in viral keratitis, two are very important in the corneal diseases, that is herpes simplex keratitis and herpes zoster keratitis. So, let's get started. Herpes simplex keratitis. Introduction. Hepatic eye disease is the most common infectious cause of corneal blindness in the developed countries. As many as 60% of the corneal ulcers in the developing country may be the result of herpes simplex virus, and 10 million people worldwide may have hepatic eye disease. So, it is a very common viral keratitis of developing countries, and worldwide it affects about 10 million people. So, what is herpes simplex virus? Herpes simplex virus HSV is enveloped with a cuboidal capsule and has a linear double stranded DNA genome. So, what is it saying? That it is a cuboidal capsule. Cuboid is this cuboidal capsule, and there is a double stranded DNA genome. There are two subtypes, HSV1 and HSV2. Basically, the HSV1 affect the mouth and HSV2 affect the genitals. The two subtypes are HSV1 and HSV2, and these reside in almost all neuronal ganglia. HSV1 causes infection above the waist, principally the face, lips, and eyes, whereas HSV2 causes venereally acquired infection, genital herpes. So you can say one is above the waist and two is below the waist, that is genitals, and first is around the face. Rarely, HSV2 may be transmitted to the eyes through the infected secretion, either venereally or at birth. Neonatal conjunctivitis. HSV2 transmission is facilitated in condition of crowding and poor hygiene. So, what are the risk factors for the transmission? That is crowding and poor hygiene. So, one is a primary infection, and then second is a recurrent infection. Primary means that the first time a person gets infected, it is called the primary infection. Primary infection without previous viral exposure usually occur in childhood and is spread by a droplet transmission or less frequently by the direct inoculation. So basically, any droplets when transmitted are in contact with a person, then a person get a HSV infection, or very infrequently by the direct inoculation. Due to protection by the maternal antibodies, it is uncommon during the first 6 months of the life. So it is usually it does not affect in the first 6 months of life because a baby is protected by the maternal antibodies. Occasionally, severe neonatal systemic disease may occur in which early diagnosis and intravenous antiviral treatment are critical to reduce mortality and disability. So, in a case of neonatal infection, it is very important that we give the antiviral intravenous antiviral treatment, because they are very critical and it can cause mortality. So that is why we start the IV antiviral. The presence of maternal antibodies mean that a dendritic corneal ulcer may be seen. So basically, in the maternal antibodies, if the it can fight against the viral, so a dendritic ulcer can be seen in case of a maternal antibodies presence. Most primary infections with HSV are subclinical. Subclinical means that a patient does not have any aggressive symptoms. It is usually very subclinical, and we could not diagnose it if, with the rare with mild symptoms, or cause only mild fever, malaise, and upper respiratory tract symptoms. Blepharitis and follicular conjunctivitis may develop but are usually mild and self-limited. So in case of eye infection, if it is a primary infection, the patient may get a follicular conjunctivitis and a blepharitis. but it is usually self-limited. That means it resolves on its own. Treatment, if necessary, involves topical acyclovir ointment for the eye and or cream for skin lesion, and occasionally antiviral. So if a person needs to be treated, the treatment is with the topical antiviral ointment, and if there is a skin lesion, we give them a antiviral cream, and if there are, sometimes the oral antivirals are also necessary. There is unfortunately no evidence that antiviral treatment at this stage reduces the likelihood of the recurrent disease. So the antiviral treatment does not reduce the recurrence of the disease. Now, second is a recurrent infection. It means the first uh, person already was infected first time, and now he is again present with the episode of HSV. Recurrent disease reactivation in a presence of a cellular or humoral immunity occur as follow. So, in a case of primary infection, the basically HSV starts go and reside in the neuronal ganglia, and when there is a patient is immunocompromised and there is a less immunity, the patient got the recurrent infection. So, how does it occur? After primary infection, the virus is carried to the sensory ganglion for that dermatome, for example, trigeminal ganglion, where latent infection is established. Latent virus is incorporated into the host DNA and cannot be eradicated with presently available treatment. So, what happens that first time a person get affected, it start getting residing in the neuronal ganglia, and it become a part of the DNA, and where it is a case of a latent infection, and it does not when a patient is immunocompetent, it does not reactivate it, but when a patient is immunocompromised, it gets reactivated. Subclinical reactivation can periodically occur, which HSV shed and patients are contagious. Subclinical reactivation is means that a patient is not symptomatic, but or she is shedding the virus and is contagious during that period. Clinical reactivation. Then there is a clinical reactivation. A variety of stress factors such as fever, hormonal change, ultraviolet radiation, trauma, or trigeminal injury may cause clinical reactivation, where the virus replicate and is transported into the sensory axon to the periphery. So in case of clinical activation, so this is a neuronal ganglion, and this is in uh, sensory fibers, axons. So what happens that there are multiple factors: stress, UV radiation, trauma, anything which immunocompromised status, then the virus starts getting replicated. When the virus starts getting, it moves to the sensory ganglions and affect the periphery. Now then what happens is a pattern of disease depend on the site of reactivation, which may be remote from the site of a primary disease. Hundreds of reactivation can occur during a lifetime. So how it is a pattern of disease depends where which dermatome is affected. It can be in the back, it can be on the face, and that is how it is presented, and it can be different from where the primary infection was occurred. The rate of ocular recurrence after one episode is about 10% at 1 year and 50% at 10 years. So, the higher the number of previous attacks, the greater the risk of recurrence. So, recurrence increases with age. So, if the basically at 1 year, only 10% of the cases get recurred, but in case of but after 10 years, the 50% of the cases get recurred, and the recurrence depend upon the number of recurrences. If the patient is having a recurrent disease, it means that he is gonna recurrent be in the recurrent in the future as well. Risk factors for the severe disease which may be frequently recurrent include atopic eye disease, childhood immunodeficiency or suppression, malnutrition, measles, and malaria. Inappropriate use of topical steroid may enhance the development of geographic ulceration. So, in case we use very cautiously the steroids in case of viral infection, because it can lead to dendritic ulcer into a geographic ulcer. Tip: herpes simplex is the commonest infectious cause of the corneal disease in the developed country. Now we have multiple corneal layer involvement in case of herpes simplex keratitis. It can be epithelial keratitis, it can be deciform keratitis, it can be stromal keratitis, neurotrophic keratopathy, and iridocyclitis. It is the basically the presentation of the different kinds of herpes keratitis. So we are going to start about the epithelial keratitis. Basically, in epithelial keratitis, the herpes simplex is affecting the epithelium of the cornea. So that is why it is epithelial keratitis. So what are the clinical features of epithelial keratitis? Let's see. Epithelial or dendritic or geographic keratitis is associated with active viral replication. So if the viral is replicating, then it gives the dendritic or the geographic ulceration. So what are the symptoms? Symptoms are the mild to moderate discomfort, redness, photophobia, watering, and blurred vision. These are basically any keratitis usually present us with the photophobia, blurring of vision, and discharge. Sign is approximately in chronological order. What does chronological order means? That first there will be this sign, then this sign, then this sign, then this sign, then this sign. So first we got the reduced visual acuity. First patient present with the decrease in the visual acuity. Swollen opaque epithelial cells arranged in a coarse punctate or stellate pattern. So epithelial cells are swollen and they are present in a case of a coarse punctate like this or stellate pattern. Let's see figure 7.12a for that. A is a satellite lesions. So you can see here is a satellite lesion. Here is a satellite lesion. Small lesions. And here is a big lesion, but around it is a satellite lesion. Now, second is a central desquamation result in a linear branching dendritic ulcer, most frequently located centrally. The branches of the ulcer have characteristic terminal buds and its bed stains well with fluorescence. So you have to remember this line by heart in case of a herpes keratitis. Why? Because it is a very classic pattern of the herpes simplex keratitis. First of all, it affects the center of the cornea, and it has a terminal buds, and its center of the base of the ulcer stains very well with the fluorescein. So it is a characteristic pattern of the epithelial keratitis. You can see in figure 7.12p. So here it is. You can see that there is a dendritic ulcer and it is central, that is involving the visual axis, and there is a terminal bulb and its center of the base is very clearly staining with the fluorescence under the cobalt blue filter. The next is the virus laden cells at the margin of the ulcer stain with the rose bengal. This may help distinguish herpetic ulceration from the alternative condition, particularly atypical recurrent corneal abrasion. So virus laden cells at the margin. So this is ulcer, this is the base of the ulcer, and this is the margin. So the margin stains very well with the rose bengal. Why? Because there is a virus laden cells in there, and it helps to distinguish us between the atypical recurrent corneal abrasions. Corneal sensation is reduced. Now we can see figure 7.12c that you can see how well the margins of the ulcer are staining with the rose bengal. And why is that so? Because there are viral laden cells. Now second is that inadvertent topical steroid treatment may promote progressive enlargement of the ulcer to a geographical or immobile configuration. So in this case, in a case of a herpes simplex keratitis, if a patient is using somehow steroid, then it rapidly progresses to geographic ulceration. Figure 7.12d, you can see that. So you can see how it is showing a geography, a map shape in this case. Next is mild associated subepithelial haze is typical. Anterior chamber activity is may be present but is usually mild. So these are very mild sign. The major important sign is in the epithelial keratitis is uh, the dendritic or geographic ulcer. Follicular conjunctivitis may be associated. Topical antivirals may also cause this. So follicular conjunctivitis may also be associated, but it can also be associated with the topical antiviral that is using. Vesicular eyelid lesion may coincide with the epithelial ulceration. So epithelial ulceration, there is a vesicular eyelid lesion. Elevated IOP is not uncommon. Tonometry should be performed on the unaffected eye first and a disposable prism used. So what we do, we elevated IOP is also common because of the mild anterior uveitis. So we use the tonometry to do this. First we take the measurement from the unaffected eye, and then we use a disposable prism for the affected eye. Following healing, so what happens if the ulcer heal? So following healing, there may be persistent peace, punctate epithelial erosion, and irregular epithelial that settles spontaneously and should not be mistaken for the persistent active infection. A hold epithelial appearance commonly results from acidious especially topical prolonged topical antiviral instillation. So maybe after healing there can be a long time chronic peace, but this is not an active infection. Mild subepithelial haze may persist for weeks after the epithelium heals. In some cases, mild scarring may develop, which tend to become more evident after each recurrence and may eventually threaten vision. So subepithelial haze can cause scarring and reduced vision, and it can persist even after weeks, and recurrence tend to worsen this condition. Recurrence may occur after a corneal graft undertaken for stromal scarring 7.12 and it can also recur after the corneal graft surgery. So you can see in this picture that there is a residual subepithelial haze after the settling of the viral keratitis, and in this case you can see the recurrence of the herpes keratitis after the corneal transplantation. So what are the investigations that are performed in case of herpes keratitis? Investigation is usually unnecessary as the diagnosis can be made clinically. Pre-treatment scrapings can be sent in a viral transport medium for culture. PCR and immunocytochemistry are also available. So we tend to diagnose it clinically, but if one is not sure, we can do PCR for that purpose as well. GIMSA staining show multinucleated giant cell. So what did the GIMSA staining show? Multinucleated joint cell. HSV serological titer rise only on primary infection, but can be also used to confirm the previous viral exposure, usually in case of stromal disease when the diagnosis is in doubt. Basically we do not do such type of investigations, but in case of HSV serology is usually positive if there is a primary infection, but we can also to diagnose it if there was any previous type of infection. So what are the differential diagnosis of the current dendritic ulceration? So differential diagnosis of the dendritic ulcerations include herpes zoster keratitis, healing corneal abrasion, pseudodendrite, acanthamoeba keratitis, epithelial rejection in a corneal graft, tyrosinemia type 2, epithelial defects of the soft contact lenses, and toxic keratopathy secondary to topical medication. So these are all differential diagnoses you can consider in mind in case of a viral keratitis. It has been recently reported that a dendritiform keratopathy can be caused by a polychondrium 1, a common preservative in a contact lens solution, and a tear replacement product. So it is very important that this is a preservative polycord that is used in a case of a tears, and in case of a contact lens solution. So that also can cause dendritiform keratopathy, remember that. Now, what is the treatment of HSP disease is predominantly with nucleoside purine or pyrimidine analog that disrupt the viral DNA. So what is how we uh, give the nucleoside analog, and this disrupt the viral DNA. The majority of the dendritic ulcer will eventually heal spontaneously without treatment. So basically, with the viral disease, it spontaneous resolve, but but the antiviral treatment is used for this to treat early and for the scarring and vascularization. Though scarring and vascularization may be more significant. So how it we treat? First, we will give topical treatment. The most frequently used drugs are the acyclovir 3% ointment or ganciclovir 0.15% gel, each administered 5 times daily. So how when we give acyclovir 5%, 3% for 5 times a day, and 5 times a day, and for 10 days or 1 week. Trifluridine is an alternative but require instillation up to 9 times daily until the epithelium closes, and then 5 times daily. So how the trifluridine is given? It is given until the epithelium heals, and it is usually given 9 times daily, and when the epithelium give, we change the dose regime to the 5 times daily. The drugs, these are relatively non-toxic even when given up to 60 days. They have approximately equivalent effect, acting preferentially on the viral laden epithelial cell and penetrating effectively into the stroma. So they penetrate very effectively into the stroma. 99% of the ulcer heal within 2 weeks. So within 2 weeks, the patient tends to get healed up. Idoxuridine and vidarabine are older drugs and are probably less effective and more toxic. So these are more toxic drugs and they are older drugs. So debridement. When we do debridement may be used for resistant cases. The corneal surface is white with a sterile sponge and a cotton tip applicator. Epithelium should be removed 2 mm beyond the edge of the ulcer, since involvement extends beyond the visible dendrite. So for example, this is an ulcer. This is an ulcer in the cornea. We tend to debride at least 2 mm more than this. Why? Because basically the viral are usually present beyond the margin of the ulcer as well. The removal of the virus containing cells protects adjacent healthy epithelium from the infection and eliminates the antigenic stimulus to stromal uh, inflammation. So what does it do? It basically protects the healthy epithelium around it, and also eliminate any stimulus that is giving for the stromal inflammation. The topical antiviral should be used in congestion. Then we give antiviral treatment of that. Signs of treatment toxicity. So what are the signs of treatment toxicity? Include superficial punctate erosions. So superficial punctate erosions like this, hold epithelium, follicular conjunctivitis, and rarely punctal occlusion. Absence of a epithelial holding with a persistent epithelial lesion raise the possibility of a poor or non-compliance. Then we can also give the oral antiviral therapy in which cases. Oral antiviral therapy, acyclovir 200 to 400 5 times daily for 5 to 10 days, famciclovir or vaxiclovir is indicated in a case of immunodeficient patient. We do not give it every patient. We give an immunodeficient patient, in children, and a patient with a marked ocular surface disease. It is an effective alternative to topical treatment when the latter is poorly tolerated or in resistant cases. The newer oral agents may be better tolerated than acyclovir and requires less frequent doses, but topical regimes are not yet identified. So we do not give oral antiviral treatment just for epithelial keratitis. We give it when there is an immunocompromised status, and in children in case of associated anterior uveitis, and in case of a patient with a poor marked surface ocular disease. Then there is an interferon monotherapy. Interferon monotherapy does not seem to be more effective than antiviral, but combination of a nucleoside antiviral with either interferon or debridement seem to speed healing. So basically, it does not have any more effective. It is only effective more when it is in conjunction with the topical antivirals. Skin lesions may be treated with acyclovir 5 times daily as for cold sore, and if extensive and oral antiviral may be given. Cycloplegics homoatropine 1% once or twice daily can be given to improve comfort if necessary. Topical antibiotic prophylaxis is recommended by some practitioner, but it's usually not given. IOP control. If glaucoma treatment is necessary, the prostaglandin derivatives should probably be avoided. We avoid prostaglandin in case of any kind of uveitis or any kind of infection or inflammation, as they promote herpes virus activity and inflammation generally. Topical steroids are not used, so these are not used, more used medication. Topical and topical anti-glaucoma topical steroid are not used until significant deciform keratitis is also present. We will see how we use topical steroid in case of an associated deciform keratitis. Slow healing of frequent recurrence may indicate the presence of a resistant viral stain, and an alternative topical agent or debridement may be tried. In especially refractive cases, a combination of two topical agents with oral valciclovir or famciclovir may be affected. A significant minority of resistant cases are due to varicella zoster virus. So we give, in a case of very recurrent, what can we use? We can use two antiviral with a oral antivirals. Tip: topical steroid should not be used in epithelial herpes keratitis, as this can result in corneal perforation. So that is it for the cornea part 7. We will discuss the deciform keratitis in the next video.